So I'll start off by giving a perspective on how times are changing. And so if we look at industrial and technological revolution in human history, if you see, it took us close to 100 years from going from steam engine to a car, and then another 100 years to go to a plane, and then develop nuclear power. And then it took another 100 years to go to a smartphone. But then we are going very fast from EVs and iPhone and now to ChatGPT. And this slide was made by ChatGPT. In fact, I just put it in and it prompted me all these facts very quickly. In fact, it also gave me a template of a slide which was not as fluid as this, so I just put it in the PowerPoint to make it more cleaner, but it took me a second to do this. But then it kind of puts you in perspective how times are changing for bladder cancer, as it took some time to go. It took 30, 40 years to going from cisplatin to gemcitabine, finding dose-dense MVAC, another 8, 10 years to go to carboplatin. But then in the last 8 years, things are changing very rapidly. We have a slew of approvals with immunotherapy and targeted agents and combinations. And so times are good for our patients and the landscape is changing rapidly. And so it's good to talk about changing paradigm whenever we have an opportunity to discuss this. So then EV302 is now the new paradigm for bladder cancer. This is a phase 3 trial presented last year at ESMO, looking at patients with metastatic bladder cancer who were treatment naive, and they were randomized to receive EV Pembro versus standard chemotherapy, which is platinum-based chemotherapy, either cisplatin or carboplatin, in combination with gemcitabine for maximum of 6 cycles. The treatments were, outcomes were kind of out of the chart in terms of survival. If you look at the median overall survival doubled from 16 to 31 months. And it kind of stayed the same for both cisplatin eligible and ineligible group who did very well with EV and Pembro combined. If you look at a breakdown of different types of responses, close to 30%, so a third of patients walking into our clinic would achieve a CR starting on EV Pembro. Another 40% had partial response and then stable disease. So if you add them up, close to 90% of the patients will see some form of response. So 9 out of 10 patients having response to first-line therapy in metastatic bladder cancer now with EV Pembro. And in fact, this response was irrespective of whether the patient can get cisplatin or not. Remember, cisplatin was the standard of care for bladder cancer and is clearly far better than other combinations of carboplatin. And now we don't have to think about it. So now the cisplatin eligibility question goes away because EV Pembro can technically be given to, in fact, anyone who can get EV Pembro, unless they have a contraindication for immunotherapy, but they can certainly be getting that combination. And if you look at the subsequent line of therapies in patients who were on these treatment arms, you see that a lot of patients got platinum-based combination after they progressed on EV Pembro, which means that folks who are progressing on EV Pembro can still get a platinum-based combination, which was the de facto standard before last year, December, when EV Pembro was approved for first-line indication in bladder cancer. At the same time, GemCis-Nivo was another study which was presented, which is Checkmate 901, which had a cohort C and D where it was comparing GemCis-Nivo versus GemCis. And this study was also positive with, if you look at median overall survival of close to 20 months, I don't think this slide has it, but less than EV Pembro, but clearly better than GemCis alone. And if you look at CR rates of close to 20%, so doubling of response CR rate with adding nivolumab, and similar partial response in stable disease. But then, the outcomes, this clinical trial focused on cisplatin eligible patients. So then applicability of GemCis-Nivo is not as far reaching versus EV Pembro. And then certainly EV Pembro median OS is far better. If you look at subsequent lines of therapy, also were limited when these patients progressed on platinum, as they didn't have access to EV. So once the patient progressed on first line, EV was already approved in that setting versus chemotherapy. based on EV301 data, where the EV median OS was 13 months versus 9 months of second-line chemotherapy. And we were very well aware of all the toxicities of EV from using EV as a single agent in the last 7 years. It's because since at Mayo we also had the clinical trial, so we had a more extensive experience with EV to begin with. And so the clinical side effect profile for a new physician who's going to use them, maybe little bit of learning curve there by looking at glucose issues and rash. But once you get a hang of giving patients EV, I think we can safely administer this drug in our clinics and have the remarkable outcomes which we are seeing with this combination in our patients. Sacituzumab was also another option which was approved based on an expedited approval with Trophy U-01 trial, but only because this deck was prepared, a month ago. But Gilead took away the voluntarily withdrew their approval for SASI yesterday, so this slide would not be valid now. SASI is not an option for bladder cancer anymore, where it was approved and we had used that in our clinic with decent activity, but the phase 3 trial turned out to be negative with increased mortality due to febrile neutropenia, so the trial was negative. Pembrolizumab has also was the previous second-line therapy in patients who had progressed on chemotherapy, and it was approved based on overall survival benefit and with median OS of 10.3 months versus 7.4 months in patients who had progressed on platinum or who could not receive chemotherapy. These patients, and so now do we have anything in precision medicine? So we have patients who have FGFR3 mutations or HER2 positive disease. So now we have two options for those patients. If they have an FGFR3 alteration, these patients can receive erdafitinib based on the phase 3 trial, looking at erda versus chemotherapy. The median OS in patients with FGFR mutations is 12 months versus 7 months. The drug is very hard to take and give for both physician and the patient because we have to monitor the toxicity very closely. Nearly every patient that I have given this drug, they had central serous retinopathy. Because we watched them very closely, I haven't had anybody who had a permanent damage from it, but it is a concern, and we see that in the clinic, and we have to manage their phosphate and dose modify. So hard drug to take, but I would certainly offer it to a patient who has FGFR3 because it does improve overall survival. And the most latest kid on the block is Enhertu, which was already approved in breast cancer. But then based on this pan-tumor O2 study, phase 2 trial has received an expedited approval in bladder cancer a few months ago. And so we have started to test all our patients who have bladder cancer with IHC for HER2. And the drug is approved for IHC of 3+. So it is, in fact, much easier to give versus erdafitinib because the toxicities are kind of something which we are used to using a topoisomerase inhibitor tagged to an antibody, so can cause cardiac and lung issues. So we are kind of used to monitoring them with ADCCs, and so we can handle them better. So I have not actually given this drug. I do have a patient who is HER2 positive, and I'll be starting them on very soon. So I'll be able to share my experience in maybe next year if I'm invited here about the activity of the drug. Toxicity, as I said, is kind of similar to what you would see with chemotherapy. So this is the most important slide which I wanted to kind of spend some time. I think the slide got a little messed up because of the Mac and Windows change in format. But essentially now we don't see patients from an eye of platinum eligibility when they walk into our clinic. If we see now patients, are they eligible for chemotherapy or are they ineligible for chemotherapy? This is a complete change in paradigm since December 2023 when EV Pembro got full approval. Now everybody who walks into our clinic gets EV Pembro unless they are ineligible for immunotherapy due to some autoimmune disease. Once they receive it and they progress, then they can still get platinum-based combination. And after they receive the platinum-based combination, if they progress, we would have already tested their tumor for FGFR and HER2. If any of them is positive, then we would put them on either erdafitinib or Enhertu. If the tumors are negative, which can happen in 6 or 7 out of 10 patients, then we would go for a clinical trial or a single-agent chemotherapy, likely a taxane-based therapy. If a patient is chemo ineligible, then I would probably start them on immunotherapy alone and look for any mutations. And sometimes after receiving precision medicine, the patient's performance status improves and they can handle therapy, then I can try to expose the patient to chemotherapy, which would be enfortumab, which I feel that is very highly active and more selective for our patients. If the patient, if all approved drugs are available and patient cannot receive immunotherapy, in that case, I see how what are the comorbidities, and I may start patients with enfortumab or gem platinum without immunotherapy. And then if they progress, I would switch them to enfortumab or platinum to the other agent, whichever I have used in first line. And then at the same time, look for precision medicine markers and then transition them to third line ERDA or trastuzumab, and then go on to clinical trial or single agent chemotherapy. So these two slides are the kind of most important slides, and they kind of reflect the new norm for bladder cancer, a new way to look at patients who are walking into our clinic and how we treat them. Thank you.